I'd like to float the idea that secondary prophylaxis is about our performance, and I'd like to, for this group and other people involved with providing secondary prophylaxis for rheumatic heart disease, to take the word compliance and strike it out of every document and every conversation from now on, and replace it with two words: service provision and or service delivery, so that we need to, I think, rethink as to our role in service delivery with regard to secondary prevention. When the Deputy Mayor of Katherine died, he went to heaven and was asked to, on his first night, was asked to actually get up and give the after dinner speech, and he was asked to talk on the Katherine floods, and so he got into his room and prepared a few notes, and there was a nice dinner, and actually God was chairing the after dinner speeches, and he said, well, you're coming up now, you're going to be speaking. And so he rose to his feet, and just before he was about to talk, God said, I just thought I'd let you know that we have Noah in the audience tonight, which is for those people who get up to speak and realise that there are some Noahs in the room, that it must be quite daunting. But the three people of Noah stature and wisdom with regard to secondary prophylaxis for rheumatic heart disease are indeed in the room. And I'm going to be, first of all, I'll introduce the whole three of them and they can come up. Paula Harrison, when you mention secondary prophylaxis in the top end of the Northern Territory, you mention Paula Harrison's name with hushed reverence, because she is the person in charge of the secondary prevention program at Ngawaka, and she has a service delivery record which is the best in the country. Not only the best in the country, but the best in the country by a country mile. So she's achieved what no other service has achieved, and it'd be really handy for us to hear from her as to how she did that. Also, the fantastic work in the South Auckland region that Nigel was talking about, the two people that really have been major contributors to this have been Catherine Atkinson, who's a district nurse by trade, and she's the rheumatic fever and rheumatic heart disease resource nurse, and she's in the country's and Manukau District Health Board, and she's a unique New Zealander in that her entire family has not any interest in rugby whatsoever, and her children, in fact, are soccer fans. In fact, she's had children who have played soccer for her country, and one child actually currently in Beijing. Is that right? Yeah. Martha Ngawaka is born in the very north part of the North Island called Whangape. That's how it's pronounced, is it? Yes. She's a community health worker, rheumatic fever, rheumatic heart disease, of enormous experience, and has some really interesting things to tell us. And she also works in the South Auckland region with Catherine. And so I'll invite those three people to come up and tell us how they did it. We in fact have used the program at Ngawaka, or Owen Pelly's the other name for the community, to base our CQI program on how she did it. So, Paula, how did you do it?
Ngawaka in 2001, And for people that don't know where Goombalanya is, it's about 3.5-hour drive south, slightly west of Darwin. And we have a population of 1,400 people. And the community's got a river surrounding it and therefore can be cut off by road for up to 5 months a year. So even though we're not that far from Darwin, we can be quite isolated, and we have about 9 outstations, which are up to 6 hours return drive, and also you can't get there by road in the wet. So in 2001 we had about 45 clients with rheumatic heart disease who required monthly medication. At this time, clients chose if they wanted to be on oral or needles, and there was about 60% that chose to be having the needles, but for both oral and for the needles, I hate this word too, but it's just easier to say. I don't use it usually, but for oral and LAs, the compliance was very sporadic, especially for males. So staff decided to come together and make it a priority to try and get all clients changed from the oral penicillin to the LA bicillin, and to try and improve the compliance of the LA bicillin. When talking to clients, the problems that arose were clients found the LA bicillin too painful, therefore chose not to come, did not remember when they were due. When they came to the clinic, they had to wait too long. They had no rapport with the ever-changing staff. Clients actually were seen in the clinic when they were due, and staff did not give the LA bicillin as it was overlooked and just seen for something else minor. And a lot of the time the clients are quite shy and didn't actually say, what about my needle? So the solutions to try and improve the noted concerns was, firstly, the staff decided it needed to become a program that one nurse overlooked and took responsibility for. The program nurse spent time to get to know each client in aim to form some trust. We now give 1 ml of local anaesthetic prior to every LA bicillin. And we also ask all new and relieving staff to do this also, even for children. Our driver picks up and/or informs clients when they are due. On arrival to the clinic, clients are fast-tracked. All staff give the LA bicillin, not just the program nurse. However, if problems arrive with the client, such as not presenting, it is the program nurse who goes and speaks with the client. Talked with staff and we realised many things were being missed with clients when they presented with acute reason, such as they came for an injury but weren't given their LA bacillin chronic disease or immunisations. So we came to agreement to spend more time with all clients and review all aspects of care. We also placed a bright recall sheet in the front of their notes. So our compliance for males in 2001 was 40% for the needles. For the last 6 years, compliance has been both for males and females, about between 90% and 95%. So, but the clients are amazing. We've got one girl that each child that has been diagnosed when they're about 12 has gone through petrol sniffing, ganja, and they still, in 6.5 years, have only missed 1 needle. And that's just, they've had 5 heart surgeries and they're just amazing. That's the story.
What's the most important thing?
The relationship with the nurses, or like forming a relationship and having, like a lot of people will say now, oh, so what's going to happen when you go? But the clients now are actually just ringing us up and saying, when am I due? And it's not always asking me. And they'll go to another community. The only reason for someone not to have a LA bacillin for rheumatic heart in our community is they're not there. And then we rely on chasing up other communities to see if they can give it while they're there. So I think it's the relationship.
Right. Well, tell us the New Zealand experience and how you've done it.
Well, we can just talk from Counties Manukau, really, which is just part of Auckland. And we're one of the fastest growing areas of New Zealand with a population of 450,000. It's a very diverse population with high service requirements. It's got a high population of Maori, Polynesian and Asian people, and they're very deprived with low socioeconomic areas of low education, unemployment, poor access to healthcare, infectious disease rates are high, particularly in children. The impact of poverty and poor housing and overcrowding creates a huge higher health risk. How do we get it to work? Well, it's all teamwork, really. In 2006 in Counties Manukau, we had 314 rheumatic fever patients, so it's alive and kicking. 62% of those were Pacific people. Most were from Tonga, then would come Samoa, then would be Rarotonga, Niue and the Tokalaus. Maori was 34%, Indian and Asian were 3%, and 1% was European. At the moment, when I had a look at the stats, there was 443 at the moment, but we think the increase is probably due to more awareness and better diagnosis. We have a wheel of support, and it really starts right when the patient is being diagnosed in hospital, and Middlemore is our base hospital. And our Children's Hospital Kids First was opened in 2001. And at that stage, there was a working party established and a discharge planning pathway was developed. The Auckland Rheumatic Fever Register, as Nigel said, was established in 1983. It's a surveillance register, as well as being a database for prophylaxis management. And once the clinician completes that rheumatic fever protocol, which he said is, really complex, and prior to the patient's discharge, and that's when it's forwarded to the register. And rheumatic fever is a notifiable disease in New Zealand since 1984. And Martha can talk about her role as community health worker.
Does this thing move?
You can push the mic towards you there.
Okay, thank you. Kia ora, tēnā koutou katoa. Greetings and hello from New Zealand. We would like to acknowledge the original owners of this land on which we are on today.
Our community health workers' role was first established in 1980, identified in later years as a cultural need to support the patients and their families. The first contact for community health workers with the patients and their families is made once notified by ward staff of new admissions.